I'm Dr. Ken Landau. Thanks for joining us. Tonight we're going to be discussing erectile dysfunction. The question is, what is it? What causes it? What can we do about it? Is testosterone therapy an appropriate treatment? Where do therapies with Viagra and Cialis and Levitra, where do they fit in? What's the likely outcome of therapy? Are most people happy with the kind of therapy they choose? Are there options other than what we've just mentioned? Well, before we do any of that, we have to arrive at a definition. What is erectile dysfunction? And obviously it means different things to different people, but what we can say is that sort of a commonly accepted definition of erectile dysfunction is the inability, the persistent inability, to either attain or to maintain penile erections sufficient for satisfactory sexual performance. Now, typically that means vaginal intercourse, but it doesn't necessarily have to. We know that there are a lot of issues associated with erectile dysfunction, issues that have a lot to do with quality of life, interpersonal relationship items. So we know that quality of life, self-esteem, self-image, emotional stress. Some people with erectile dysfunction seem to avoid physical contact with their significant other, withdrawal of intimacy. There is avoidance of physical contact. All of this is a problem that we talk about as being a relatively new problem, but it's existed for more than 5,000 years. It was written about a long time ago in the Egyptian records. We know also that even though people talk about erectile dysfunction and talk about it now quite openly, we know that about half of the men who suffer from the condition don't seem to be all that bothered about it, don't seem to be concerned about it. So the question is, how common is erectile dysfunction? And if you look at the medical records, you would say, this is a phenomenally common problem. It's estimated in the United States, probably somewhere around 18 million adult men suffer with the condition or have the condition. We know of those, about 7 million probably are so severe that they're not responsive to even the oral therapy. We know that it's estimated in the world that by the year 2025, we're going to have erectile dysfunction affecting somewhere around 320 million men. If you look at some of the studies here in the United States, you see that the incidence of erectile dysfunction, well, if we look at a Boston study known as the Massachusetts Male Aging Study, looked at men between the ages of 40 and 70, and what they found was a whopping 52% of men complained of erectile dysfunction, at least at some time. So mild, moderate, or severe. In a study of general practitioners in London looking at men between the ages of 18 and 75, almost 9% suffered from erectile dysfunction. So common no matter what our definition is going to be. We know that if we look at therapy, well, between the ages of 40 and 60, of those people who complain of erectile dysfunction, probably only about 1 in 3 seek any kind of medical therapy, and it seems that sexual relations are not as important to older people, so we know if we look at people over age 65, fewer than 20% seek medical therapy. Now, as we look on, we can say that, well, of the 6.2 million men in the United States who have erectile dysfunction at the present time, according to one study, somewhere around 25% or 1.6 million are on therapy, but that means that about 4.5 to 5 million men with erectile dysfunction, mild, moderate, or severe, are not seeking any kind of therapy. 75% do not seek therapy. Now, in the study I talked about a moment ago, the Massachusetts Male Aging Study, looking at the men between the ages of 40 and 70, they found that a little more than 50% suffered from some type of erectile dysfunction. Mild erectile dysfunction, around 20%. Moderate erectile dysfunction, of the 50%, it was about 25%. And if we look at severe erectile dysfunction, relatively uncommon, so about 10% of the men with erectile dysfunction. So in other words, If we look at those men who have mild erectile dysfunction, maybe it's going to come in at around 7-8%. Moderate erectile dysfunction come in at somewhere in the general population, somewhere around 10-15%, maybe about 5% with severe erectile dysfunction. If we look at men less than age 40, overall we find that somewhere around maybe 8% of men suffer from erectile dysfunction. If we look at men between the ages of 40 and 50, well, that number can go up to about 1 in 6. If we look at men between the ages of 50 and 60, maybe 1 in 4 men. And if we look at men over age 50, or 60 rather, well, probably somewhere around 50% of men suffer from at least temporary erectile dysfunction. Now, the incidence, the number of new cases, increases obviously as we grow older. So if we look at men between the ages of 40 and 50, in 1,000 men, we're going to find about 12 of them in a given year are going to develop new case of erectile dysfunction. So about 1% of men. If we look at men between the ages of 50 and 60, over the course of any given year, well, somewhere around 3 out of every 100 are going to suffer from erectile dysfunction, new case, and that adds obviously to the last year's case and the year before case and the year before case. That's where we get to such high numbers as half of all men between 40 and 70. And if we look at men between 60 and 70, we find that maybe about 5% of men per year are going to develop erectile dysfunction. Now, if we look at complete erectile dysfunction, men who have no sexual function, no ability to either attain or maintain an erection, we find that at age 40, it's about 5%. At age 60, it's about 10%. At about age 70, it's 15%. And if we look at men over the age of 80, somewhere in excess of 30%, probably considerably higher. Who makes the diagnosis of erectile dysfunction? Obviously, the patient has to go see a physician in order to get some sort of medical record. So if we look at those physicians who are making the diagnosis, probably about 40% of the time it's going to be a urologist, about 30% of the time it's going to be a family doctor, and about 20% of the time it's going to be an internal medicine specialist. Those figures obviously subject to change depending on availability of the different specialties. Well, question is, what is the likely cause of erectile dysfunction? And the causes are extraordinarily numerous. We divide them sort of into two general categories, two broad categories. One category is psychologic, and the other is medical or organic. So psychological. We know that in those people who have some kind of a psychological problem, maybe they have a fight with the spouse, maybe they have a significant emotional problem, maybe they're depressed, maybe they're anxious. Well, those people tend to develop erectile dysfunction of very rapid onset, tends to be relatively short duration associated with the timing of the particular problem. And these people who have the psychological erectile dysfunction, the once was called impotence, well, these people tend to maintain early morning erections and late evening erections. It seems that those men can attain the erection, but not for sexual performance. Now, if we talk about organic problems that lead to erectile dysfunction, again, extraordinarily numerous, all the way from neurologic disease affecting the brain, disease affecting the spinal cord, hormone abnormalities. Everyone thinks that it's due to a decrease in the testosterone concentration, but that's usually not the case. More often it has to do with problems with the arteries, either general or localized problem with the artery. Sometimes it has to do with the material in the penis itself, the corpora cavernosa. Those are the areas where the smooth muscle is that has to dilate so that the blood can flow in. And sometimes it has to do with taking certain kind of medications, either prescription medications or recreational medications. Sometimes, interestingly, of course, we have a combination of the psychological and the organic. Once upon a time, it was thought that most cases of erectile dysfunction, then called impotence, well, it was thought that the majority of cases were caused by psychological factors. Now it's thought that probably somewhere in excess of 80% caused by organic problems. Well, who seems to be at greatest risk for developing organic problems that lead to erectile dysfunction? Well, the usual culprits, actually. People with diabetes are extraordinarily likely to develop erectile dysfunction. We're talking about both the type 1 or the juvenile onset and type 2 or the adult onset. So as more people develop diabetes, as more people grow fatter, we know that obesity is a major cause of erectile dysfunction and cause of diabetes. It seems like the incidence is going up and up and up. Unfortunately, the number is going down and down and down. We also find that our insulin resistance, even without diabetes, is a cause. High blood pressure. Again, what does high blood pressure do? High blood pressure interferes with normal arterial function. As we have the arteries not being able to function, not being able to dilate appropriately, then we have a significant problem with blood flow to many areas of the body. That's why heart attacks and strokes are more common, and so too is erectile dysfunction. Another cause, obviously, is hardening of the arteries. So hardening of the arteries, that means elevated cholesterol, elevated triglycerides, high levels of bad cholesterol, low levels of good cholesterol, other common causes. We know in the United States right now that somewhere around a third of the population has what's known as the metabolic syndrome associated with obesity, increased weight, increased waist circumference, elevated blood pressure, abnormalities of the blood lipids, all of those associated with an increased incidence of erectile dysfunction. People smoke cigarettes. What do cigarettes do? Cigarettes lead to heart disease. Well, they also lead to arterial disease in every area of the body, including the arteries that supply the penis. And remember, the arteries that supply the penis obviously are smaller than the arteries going to the heart. So which artery is going to suffer the consequences first? Well, it's obviously going to be the small artery. The small artery, if it reduces its available circumference, the available luminal size decreases, let's say, by 50%. Well, that's going to be more of a problem in a very, very small artery than it is in a larger artery. So those people who smoke cigarettes going to be at high risk for developing erectile dysfunction. People whose diet isn't appropriate. It seems the more fats a person eats, a variety of problems that lead to the development of atherosclerosis, hardening of the arteries, again, increases the risk. And you hear so much about alcohol and how alcohol is so good for you. You should drink at least 1 or 2 drinks a day, 1 if you're a woman, 2 if you're a man, maybe, and that'll supposedly reduce the incidence of heart disease. Well, the evidence on that is not very good. And as a matter of fact, we know that if you drink too much, no question about it, if you drink too much alcohol, if you drink more than 21 units a week, 3 drinks a day, well, you're going to increase your risk of developing erectile dysfunction. Now, how bad are cigarettes? Let's go back to that for a moment. We can say that cigarette smoking is a major problem. Cigarette smoking increases your risk of erectile dysfunction by almost a factor of 2. So you basically double your risk if you're a current cigarette smoker. If you used to be a cigarette smoker, you still have somewhere of around 25 to 50% increase in the likelihood that you're going to suffer from erectile dysfunction. And even if you go out and exercise, which we obviously suggest that you do because exercise is one of the major therapies for erectile dysfunction. But if you exercise in the wrong way, let's say you ride a bicycle and you ride a bicycle for more than 3 hours a week, well, simply putting pressure on what's known as the pudendal artery, that's the artery that comes off of the iliac artery. It goes to the aorta, the iliac artery after the split going down to each leg, and then we have the pudendal artery. Well, if you put too much pressure on that, that's going to reduce the ability of blood to get to the penis, and that is going to increase the incidence of erectile dysfunction. Also, we know that obesity, we mentioned that. Well, why is obesity associated with erectile dysfunction? You ought to be able to get fat and not have any consequences. That's not the way it works, because as you get fatter, you're going to increase the incidence of hardening of the arteries, but you also find that fat is going to decrease available testosterone by a factor of somewhere between 20 and 60%. So those people who are especially overweight, sometimes people who are obese, more likely obesity, of course, defined as more than 20% over ideal body mass. Well, those people going to suffer an increased incidence of erectile dysfunction. And also we have a variety of other problems, limited physical activity. Well, that increases the risk. But so too do a variety of medical diseases. So people who have problems of the liver, you have hepatitis, you have cirrhosis of the liver, maybe from drinking too much alcohol, maybe from past drug use. Maybe you have chronic kidney disease, chronic kidney failure. Maybe you have uremia. Maybe your kidneys just don't function appropriately. You are going to be at risk for erectile dysfunction. People who have lung disease, people who have smoked and now have developed either emphysema or chronic bronchitis, people who have other lung disorders, well, they have an increased incidence of erectile dysfunction. And even men, as we grow older, we said that one of the problems is that you increase the incidence of erectile dysfunction. Well, men who are more than 50 or 60, of course, have a tendency to develop what we know as benign prostatic hypertrophy, benign enlargement of the prostate, not the cancer kind, but the benign kind. And we know that men who are over 50 or 60 have an increased incidence of what we call lower urinary tract symptoms. Now, the two might be related, might not be. But we know that people who have symptoms of difficulty starting the stream, difficulty emptying the bladder, getting up at night, people who have discomfort, well, those people have probably a significant increase, maybe as much as an 8-fold increase in the incidence of severe erectile dysfunction. Also people who have the anxiety, the stress. But we have another problem, and it's a more recently discovered problem, recently sought after problem. And that problem has to do with erectile dysfunction, as I mentioned before, in many cases has to do with shrinkage of the penile artery lumen. The lumen gets smaller, and it can't supply the blood to the penis. Now, why is this? Well, in many cases, it's thought that it's representative of the overall state of your blood vessel circulation, the arteries in your body. And we know that there is a significant correlation between erectile dysfunction and coronary artery disease, especially prominent in younger people, in younger men, in men below the age of 60. There seems to be a significant relationship between hardening of the arteries in general and hardening of the arteries in the penis. And if you have hardening of the arteries in the penis, it's not going to be able to dilate, the vessel is not going to be able to dilate and get the increased blood flow necessary for the development of an erection. So some studies were done, and these studies show quite clearly that in younger men at least, those men with erectile dysfunction have an increased risk of cardiac events, heart attack, angina, sudden cardiac death. Well, they have an increased incidence, irrespective of all of the other risk factors, the cholesterol, the high blood pressure, whether you smoke or not, just an increased incidence of about 40%, or give or take a little bit. We know that the all-cause mortality among young men with erectile dysfunction, the all-cause mortality is increased by about 25% versus expected. If we look at the incidence of stroke in those men less than 60 with erectile dysfunction, the incidence of stroke is increased by about 40%. And if we look at the incidence of heart attacks, the incidence of heart attacks is increased by somewhere around 60%. Now, these are relative numbers, not absolute numbers. Obviously, the likelihood of a man dying of a heart attack when he is 40 years old or 50 years old is relatively small, but that likelihood is increased by about 60% if that person has erectile dysfunction. Now, when we talk about the size of the vessel, it's very important to realize that the penile artery is only about 1 millimeter in diameter. It's about the tip of this pen. That's what the penile artery is. If we look at the proximal left anterior descending artery in the heart, it's about 3 or 4 millimeters in diameter. If we look at the internal carotid artery that goes up to the brain, well, it's about 5, 6, or 7 millimeters in diameter. And if we look at the artery that takes the blood to the leg, it's maybe between the sizes of 6, 7, or 8 millimeters in diameter. So you can see that we're talking about a very small vessel that's going to supply the penis. And if we get significant hardening of the artery, significant atherosclerosis, significant dysfunction of all of those little cells, we call them the endothelial cells, that line the vessel, well, if that happens, then we're at increased risk for erectile dysfunction. Why? Well, there are a lot of correlations of hardening of the arteries in general, in the heart, and in the penile artery. It has to do with a chemical that we'll talk more about later on called nitric oxide. Nitric oxide is very important in the Viagra and Levitra and Cialis story. We know that there's an increase in the tone of the sympathetic nervous system, the adrenaline-containing nerves. We know that there are more mediators of inflammation floating around, and in all of these cases, a decreased likelihood of dilation of the vessels. So, bottom line, if we look at men who develop erectile dysfunction, young men who develop erectile dysfunction, we find that there's a 2% likelihood in the course of the next year, 2%, that's significant, in 1 year for those men to develop some sort of a coronary vascular event, angina, heart attack, stroke, some sort of a problem. And if we look at men and follow them for about 11 years, well, somewhere around 8, 10, 11, 12% of men are likely to have some sort of an event. And obviously, the more severe you have, the more severe the problem of erectile dysfunction, and the longer it's been present, the greater your likelihood of suffering some sort of an event. And if we look at the people who have coronary artery disease, so you've already suffered a heart attack or a stroke or something of that nature, well, we find that the incidence of erectile dysfunction, obviously going both ways, the likelihood is somewhere around 50, 60, or 70%. And again, the statistics more predictive in younger men, men less than age 60 versus men over age 60. So that brings up another very important point. If you're a young man and you develop erectile dysfunction, is it appropriate to consider some sort of cardiovascular evaluation? And some people are saying yes, if you develop erectile dysfunction, since that's so frequently associated with hardening of the arteries in general, the increased risk for heart disease, that if you're 40 years old, 50 years old, 60 years old, and you have a problem with erectile dysfunction, maybe you need to be evaluated, because on evaluation in clinically normal men, we find that a significant percentage have already had myocardial infarction, even if they don't know about it. We know that about 80% of men who have erectile dysfunction under age 60, if they're going to have a cardiac artery evaluation, an angiogram, we know that 80% of them are going to have some sort of plaque, and we know some percent are going to have sudden cardiac death. So we know that if we look at men who have erectile dysfunction, and we put them on a treadmill, we're going to find that somewhere maybe as low as 5% to as high as 50% going to have inducible ischemia. In other words, they have subclinical coronary artery disease, even though they don't have any symptoms. Well, unfortunately, one of the first symptoms in coronary artery disease is sudden cardiac death. Why is there such a problem with erectile dysfunction? Why is it sort of the canary in the coal mine? Why is it sometimes the first symptom of coronary artery disease? Well, we call it the arterial size hypothesis. And the arterial size hypothesis just refers to the fact, as I mentioned a moment ago, that the artery is so small that if we have even limited narrowing of the artery, it's going to prevent its otherwise normal function. It's going to be associated with arterial stiffness, and arterial stiffness means that the artery can't dilate. We know that small arteries have more of the problem because they have a greater percentage of their surface covered by the endothelial cells. The endothelial cells proportionately are more important in the small arteries than they are in the large arteries. Well, they had a Princeton conference, Princeton guidelines. Princeton number 1 came out in the 2000. They sort of recognized the problem existed, the link between the coronary artery disease and the erectile dysfunction. So they suggested that men make certain that they had at least decent enough cardiovascular reserve to engage in sex. Then they had the Princeton 2 that came out in 2005, and they divided the men into 3 different groups as far as cardiovascular function was concerned: low risk for problems if they had sex, intermediate risk for problem if they had sex, and if they were in the intermediate group, then it was suggested maybe they needed a stress test. If they were in high risk, well, then it was thought that they should go and see a cardiologist and have a consultation before engaging in sexual relations. The Princeton 3 in 2012 came out and gave some guidelines, and what they suggested was that there was an increased incidence of some sort of a morbid event within 3 to 5 years of your developing the erectile dysfunction. So if we look at 1,000 men, and we take age 40, and we look at those 1,000 men over the course of a year, we find that in those men who do not have any erectile dysfunction, the likelihood of them having some sort of a cardiovascular event, coronary artery disease, is about 1 out of those 1,000. If, on the other hand, we look at men who have erectile dysfunction, follow them for a year, we find about 50 of those men going to develop some sort of coronary artery disease symptom or some problem. And if we look at men who are 50 years old, number's about the same. But once we get to about age 60 or thereabout, there isn't all that much difference between the men with and the men without. The men with erectile dysfunction still are at increased risk, irrespective of age. The difference between normal function, normal sexual function, and men with erectile dysfunction, however, less than age 60, worthwhile to consider consultation. Let's go on and talk a little bit about the anatomy. What causes an erection? Well, medically at least, we know that the penis has 2 cavities, and these cavities are called the corpora cavernosa. If you look at the penis, we have the 2 corpora cavernosa right here. So we have 2 of them, 1 on either side. We know that they're surrounded by a thick, fibrous collagen tissue. It's called the tunica albuginea, and it's through that the veins go, and the veins have to be able to get through there in order to drain. And we know that the corpora cavernosa can dramatically expand. Now, on the bottom, so we said we have the 2 paired corpora cavernosa, we have something known as the corpora spongiosum. That's on the bottom of the penis. That's where the urethra, the tube that carries the urine from the bladder to the outside, goes. Everything is surrounded by another kind, we call it Burke's fascia. Okay, that's the anatomy of the penis. Now, we know that the blood goes from the aorta down into the start of the legs. We call it the iliac arteries. The iliac arteries give off a pudendal artery. The pudendal artery is going to the penis. The pudendal artery gives a branch off. It's called a bulbar artery. It supplies the penis close to the body. And then that breaks down into 2 other arteries, something called the dorsal artery and something called the cavernous artery. And the cavernous artery goes to the corpora cavernosa, and that's what has to dilate in order to get the blood flow. All of these arteries, the small artery, the penile artery, obviously has to dilate too. The arteries break down. They get smaller and smaller. The helicine arteries, they get into the sinusoids, and they will cause the increase in the blood that goes into the penis. Now, the flaccid penis contains basically contracted smooth muscle, contracted arteries. There isn't all that much blood flow going to a flaccid penis. But with appropriate stimulation, with mental stimulation and chemical stimulation, then we know we're going to be able to relax those smooth muscles, relax the sinusoids in the corpora cavernosa, those 2 structures, 2 cylinders on the top of the penis. And when that happens, when we get the nitric oxide to be released, then we're going to have a massive inflow of blood. And when we get the inflow of blood, the penis is going to engorge. And when the penis is going to engorge, it's going to block the exit of the veins So there's more blood going into the penis than there is leaving the penis. The penis is going to get larger, and then the penis is appropriate to function for sexual activities. Now, it's very important that you also have to realize that the prostate gland that becomes dysfunctional as men get older. Well, we know that the prostate gland is a very important actor as far as the endocrine system is concerned. Now, everyone talks about testosterone itself. The role of testosterone is arguable. There is a much more important chemical, and this chemical has to do with a chemical that's altered from testosterone. And it's altered from testosterone by an enzyme that, among other places, is in the penis. And this enzyme is known as 5-alpha reductase. You know about 5-alpha reductase because that's what Proscar and that's what Avodart work on. Well, the 5-alpha reductase changes the testosterone to 5-alpha dihydrotestosterone. And it's that 5-alpha dihydrotestosterone that is going to perform the actions that we all think about within the genital system. That is the most important chemical, not the testosterone per se. It would appear that if we lose the prostate, if we lose the ability of the 5-alpha reductase to work, if we take too many of those pills, we might interfere with the ability of a person to develop an erection. Now, the tumescence, in other words, the penis going from the erect state to the unerect state, that has to do with the lack of production of some of these chemicals, the nitric oxide and the substances that we just mentioned, and a change in the blood flow and a change in the pressure within the penis. And then obviously, if we're not blocking the veins are going to start draining the blood circulation from the penis. And when they do that, then the penis becomes unerect. Now, it's important to realize that the story is extraordinarily complicated. For instance, we know that this 5-alpha reductase enzyme that we talked about, present in the prostate, is important, and all we have to do is look at what happens after prostate surgery. Well, after prostate surgery, a significant number of men, basically all men, are going to develop some period of erectile dysfunction. Part of the reason they develop erectile dysfunction is because the penis has injury to some of those nerves, and those nerves need a chemical. It's part of the brain-derived neurotrophic factors, the BDNF that you also hear about. Well, it needs those substances in order to regenerate the nerve so that it can do what it's supposed to do as far as the penile pathophysiology is concerned. After the operation, even after the robotic surgery, the nerve-sparing surgery, the nerves aren't completely spared. The prostate has lost some volume. There isn't as much of the 5-alpha reductase, so we don't have that active dihydrotestosterone that's going to be produced. And as a result, we're going to have significant sexual dysfunction after the surgery. And that's going to go on for at least a year and a half. And some men don't ever return to normal. Some men never get their normal sexual function after the surgery. Well, we also have to realize that a lot of studies have been done in animals to see how important the testosterone is and how important the dihydrotestosterone is. And we know from these studies that if we take castrated rats, they're going to obviously lose their ability to function sexually, especially if we stimulate the nerve, the cavernosal nerve, with appropriate amount of electrical impulse. Under normal circumstances, normal rats would get an erection. Castrated rats do not. If we provide castrated rats with testosterone, but we block the ability of the testosterone to be converted to dihydrotestosterone because we give the rats some of that finasteride, Proscar, we're going to find they don't have any sexual function still. They don't have the ability to attain an erection. So we need the dihydrotestosterone. The story is a lot more complicated. And in men who are taking the Proscar, some percentage of those men are going to develop sexual dysfunction, erectile dysfunction, even after they stop the medicine. We call that the post-finasteride syndrome. They're going to have sexual dysfunction that is going to continue. Now, how do you get stimulated to have sex? Well, through any number of ways. We know the central nervous system. You can become sexually stimulated because of sight or smell or taste. We know that locally we're going to have a chemical known as arginine, L-arginine, and that's going to be converted. And through the conversion process, we're going to make a chemical called nitric oxide. Nitric oxide, phenomenally important, because nitric oxide is what takes a chemical that will allow calcium to enter into the cells and then cause relaxation of the smooth muscle. And we need that to happen, so we need the nitric oxide. And we get nitric oxide through cyclic GMP. Now, there's another competing system that also is important, even though we talk mostly about the cyclic GMP and the nitric oxide, and we talk about the Viagra and the Cialis and the Levitra. Those are all the cyclic GMP. We have another competing area, and it's cyclic AMP, and cyclic AMP is very important too. And as a matter of fact, right before the medicine, first one, Viagra, came out in 1998, well, another chemical came out that was able to be injected directly into the penis that would cause the same sort of reaction. And that chemical, a prostaglandin, a PGE1, a phosphodiesterase 1 chemical, reacting chemical, well, that chemical worked on the cyclic AMP. However, if you had a choice of taking a pill or taking a shot into your penis, obviously the one that won the battle is the now famous Viagra. Well, we have a variety of other pathways also important as far as the ability to develop an erection is concerned. What we'll do is we'll come back next week. We'll talk a little bit about the whole concept of therapy. What is the most appropriate therapy for erectile dysfunction? Who decides that? Is it the patient? Is it the doctor? Combination? What about the cost of some of these therapies? And everyone knows about the drugs, the oral medications, but did you know that there are a variety of other drugs that are available, drugs that can be used in different manners? There are also a bunch of devices that can be used. So we'll talk about all of that when we come back.